So I will quickly go over complications. Really a device that will cause a lot of good for the patient, but if you are not careful, then you can cause a lot of harm as well. But as long as you follow all the steps and stick to the recommendations for your first 20, 30 cases, and you get comfortable with it and pass out with it, I think it's a very safe device to use, and it can really help your patients. It can help you, it can reduce your procedure time, and allow you to deliver stents and get a good angiographic and clinical result for your patients. So one of the biggest things for is slow flow or no reflow. And usually that happens is because of a few things. There's your burr size, so remember your 0.5 ratio, so you have to make sure that you're not oversizing the burr. The second is a lot of distal disease, right? So be cognizant of that, be thinking about that if you have an index lesion, but you have disease distal to that index lesion, then it's going to be tough for those subcellular particles to wash out and go away. For that, usually I give nitrite or calcium channel blockers, vasodilators before doing a run. I start off with a smaller burr. So say your 0.5 ratio says it should be a 175 burr. I would start off with a 1.5 or 1.25 burr so that it goes through, creates some room. The reference vessel could be, say, 3 millimeters, and you're taking a 1.5 millimeter burr, but the lesion itself is, say, 99%. So you're not going to be able to get a burr through that if it's a 0.5 ratio burr. So you're going to have to take a smaller burr, create a channel, and then take a larger burr. So think about using 2 burrs because that may make it safer for the patient. The other thing is run length. The recommendation is 15 seconds. I keep it less than 10 seconds. And I stop. Just peck at it a few times. If you're getting resistance, stop. Let the artery breathe. Let your solution wash in, and then resume. Make sure your flush is going on. Make sure your ACT is appropriate. You should not be on 2-3 inhibitors, but for planned rota, I usually load my patients with antiplatelets before I do it. So typically Plavix and aspirin is on board, not 2-3 because if you get a perforation or dissection, there will be a lot of bleeding. And then the patient as a whole, and make sure that they're okay for you to do this procedure. The other thing is dissection. So again, with dissection, sometimes it is going to happen. It's important for you to recognize it, and if you can stop, then stop. Burr to vessel ratio is clearly one of the factors in it. Multiple lesions is a factor in it. Angulation is another factor. So if you're especially doing a proximal circ or you're doing a tortuous RCA, perforation dissection is higher if you have those symptoms. So think about those, plan ahead, and maybe change your strategy if you're concerned about that. Especially for the first, I would say, 20 cases, keep it very, very simple. Straight segments, single lesions, try to keep respect case as one, but if you get a dissection, ideally you should stop, reassess, and see if you can proceed without rota from there on. Once you're an advanced operator, then you can do rota after the balloon, but for your first 20 cases, I would say don't balloon, and because that, if you get a dissection and don't recognize it and rota it, then you can get a catastrophic kind of result. Perforation, again, burr to vessel size, tortuosity are the main reasons for perforation. Have your cover stents ready. At some point when you're doing rota, you will get a perforation. It's going to happen. So just be mentally prepared for it. Every time I do it in the lab, the staff knows that we have a perforation card in the room. In case there's a perforation, we address it. And then burr entrapment, as Dr. Badr mentioned, generally thought to be more common with the 1.25 burr. I haven't experienced it luckily, but there are ways, again, tortuosity and where you stop the burr is important. Don't stop it in the lesion. When you do your 10-second, 15-second run, bring it back, stop it in a relatively healthier segment, or bring it back into the side. Make sure the wire is not stuck anywhere, and if your burr does get stuck, then there are a few ways to bring the burr back. You can use a guide liner, you can intubate your guide deep, you can inject vasodilators. And so typically if you give it time, gentle tugging, trying to bring it back, work your guide and the burr, and try to work it back and get it back into the guide. Ultimately, don't yank it out very hard, you can bust the artery, cause a tear, or worse. If the patient has to go to cabbage or surgery with a burr for burr removal, it's not the end of the world. But if you yank out a stuck burr too hard and cause further damage, then that could be catastrophic like that. So I think those are some of the important points. Everybody wants to get on the hands-on station, so let's move to that so that you can get a feel for the device and set up and see how that works.